I'm now going to turn the presentation over to Dr. Zink and her staff to discuss the science and data behind the virus as it relates to children and what we know today. Next slide. Dr. Zink.
Great. Thank you so much, Commissioner Johnson, and thank you, Chair Drummond, for our opportunity to present before you all today. I've often said that we are building the ship as we sail it, and we are incredibly grateful for the partnership of the public, of the teachers, of the superintendents, of the team that you see on here, on legislatures, our scientists and data experts, as we're all learning as quickly as we possibly can about the science and data relating to COVID. I'm going to talk about three basic categories regarding science and data regarding COVID. The first is about children and their risk of COVID. The second is thinking about communities, including teachers and their risk of transmission. And the third is really the science and education behind teaching as a whole, so that the community can be best informed with the science and information that we have. Next slide, please. So here, I'm going to start with just talking about the science of the risk to children. I will start off by saying that this is a disease that we did not know existed just a few months ago. It's been less than a year since we even knew that this virus existed, and we've been learning as quickly as possible. Famous epidemiologist once said, invite us back in 2 weeks and we'll correct all the things that we've learned. We have to recognize the fact that we are learning new things, particularly about the role that COVID plays and the effects on children on a daily basis, and the science is rapidly changing. And while we try to stay as up on it as possible, we do expect more changes in the science and literature. We do know consistently that we see most children have very mild to no symptoms if they do get COVID, which is fantastic to see. We also know that deaths in children are very rare, but have happened, and we need to acknowledge that as well. We have seen that children with underlying medical conditions are at more severe risk if they get COVID, and those are specifically diabetes, obesity. We do know that somewhere between 1/3 and half of Alaskan children are considered obese, chronic lung disease, high blood pressure, and tobacco use. And looking at our previous studies, 10.9% of Alaskan teens have smoked cigarettes in the last month, and 15.7% has used a vape pen, so are concerned about the population. We also have seen what we call multi-inflammatory system has been reported in children, similar to a disease called Kawasaki's disease. And again, the data and science on that continues to progress, but in general, kids do very well if they get it. However, there are exceptions. Moving on to the next slide. The next question is, what do we know about the long-term side effects of COVID if children get it or if adults get it? And this is an area where there is a great uncertainty and where we continue to learn on a regular basis. We're only really 6 months in, and no one has really had COVID long enough to know what the true long-term side effects are. But they we've been continuing to follow the studies closely and look at previous diseases. We have looked at other coronaviruses such as SARS and MERS, where we have seen survivors, and people who have survived those diseases have had similar severe and long-term symptoms after they have had those diseases, including lung problems, bone problems, fatigue, and PTSD-like symptoms that could last for years or even decades. Right now with COVID-19, we are seeing reports that survivors may have long-lasting symptoms such as fatigue, muscle aches, shortness of breath, even in the young and healthy people related to COVID-19. People who have been in the ICU have reported increasing fatigue, aches, shortness of breath, as well as PTSD symptoms similar to what we saw in SARS and MERS. We don't have a lot of data on here, but there was one study that came out that showed greater than 80% of people who'd been hospitalized with COVID did have symptoms 2 months later. Another way to look at that is 12.6% of patients hospitalized with COVID were symptom-free 2 months later. 44 reported worsening quality of life. 53 had fatigue, 43 had difficulty breathing, and 27% had joint pain, while 22% had chest pain. That study was done in Italy out of 143 hospitalized patients. Of note, they were slightly younger than some of the other age cohorts, with an average age of 56.5 years. 5% were intubated, and all were hospitalized. So they were sick enough to need the hospital, but not super sick for context. Next slide. The next big science question that we're always trying to understand is the role that children may play in transmitting diseases. We see this every year when schools open back up, that we see an uptake in other respiratory diseases such as RSV and influenza, and we know that school can be an effective place for transmission of other highly contagious diseases. What's known with children is still a point of much discussion and much debate, partially because we've seen this in the setting of lockdown, where children may not be interacting in their normal environments, or where schools already may be limited. And as a result, the evidence is very limited. However, they're starting to see a trend in the literature where children under the age of 10 may be less likely to get the virus, as well as less likely to transmit it to others, even when they're around others. There's estimates that that may be somewhere between 10 to 50% less likely to transmit the study based on one study. Children under the age of 10 may also be less likely to leave the house during that period of time with restrictions in place. So it's a little bit hard to know what additional confounding barriers may be involved. However, children over the age of 10 look like they may be able to get the virus as well as give it to others at least as likely as adults. And in one very large South Korean study that's been getting a lot of attention recently that looked at over 60,000 members, they were looking at children between the age of 10 to 18, and they were actually slightly more likely to give it to other members of their household than even adults were. I'm happy to go through more of that data if the committee wants, but we are looking closely at that as we help schools figure out what elementary versus middle and high school look like when we're thinking about community transmission. We definitely cannot rely that all children we cannot rely on children having a decreased transmission dynamics altogether. So again, we look at the different age groups, less than 10 and over 10, when we're thinking about the transmission components of this virus. Next slide, please. The next conversation is schools reopening and the projected community risk. Anytime we have an increased risk of people coming in close contact with each other, mixing large groups, the CDC defines a close contact is greater than 15 minutes within 6 feet of each other, which, as you can imagine, happens quite often in school. We would expect increasing transmission. Physical distancing, face coverings, such as homemade cloth face coverings or masks, hand hygiene, and encouraging people to stay home when they're sick are mainstays of any prevention effort with schools open or without schools being open. Whether the community sees an increased risk of schools reopen depends a great deal on numerous things. The biggest one is the community transmission rates in that community. Other community factors such as face coverings in public, community gatherings, the density of the population, as well as if children are staying home when they're sick, and if we're maximizing other prevention measures such as distancing, face coverings, hand hygiene, and cohorting in schools. Next slide, please. There's also risk of not reopening. The American Academy of Pediatrics issued strong recommendations in favor of holding in-person school whenever possible for the fall of 2020. School interaction is key to childhood development, and many children experience barriers that make distance learning less than ideal, including insufficient access to internet or computers, learning disabilities, language barriers. Young children in particular may not learn as well independently, and we definitely heard reports of that this spring. Schools also provide services that are difficult to deliver remotely, such as meal programs, physical activity, after-school child care, and child abuse education, as well as significant economic impacts to parents that are having to stay home or find child care. And as a result, all of these factors must be taken into account as we're making decisions moving forward. Next slide, please. The other conversation that we're often having is student mental health support. The committee chair asked that we also include in our presentation students' mental health needs, and this is a continued area of focus for both DEED as well as the DHSS staff. In this time of stress and anxiety for all children, school staff, families, community members, focusing on and providing routine, predictable, whenever possible education is essential. DEED and DSHS are providing information about mental health needs of students and adults through school framework guidance, school health webinars that will be covered in great detail in the upcoming slides, through DEED's online e-learning courses for educators. Schools are the source of mental health services for many children. For many, they're the only source of isolation, economic difficulties, and anxiety that returning to school may compound mental health problems for children. An ever-changing plan must be a constant discussion as risk levels may contribute to anxieties. Mental health services must be a part of every school's planning for in-person instruction. Next slide, please. When we're talking about Alaska's school risk mitigation approach, we want communities to look at the community level of cases, watching for early warning signs for schools, be ready to switch to in-distance learning, maximize physical distancing, wearing face coverings, hand hygiene, and minimizing mixing and age-appropriate cohorting as in additional mitigation strategies. Next slide, please. For the public as well as the community and schools information, we have created these community case level indexes that you can find on DHSS's website. There's two major tools that people can use and see, and one is a 7-day case trend as well as a 14-day case trend. We spent significant time with our team, epidemiologists, looking at all sorts of guidance, including Harvard modeling, White House modeling, CDC modeling, international modeling, to try to best understand how we could provide communities tools to look at what does the community transmission rate look in their community. Currently, these two tools use resident cases at this time. The one on the left-hand side that you can see on your screen is a 7-day case rate map, and the one on the right-hand side is the 14-day case alert map. The alert map is going to be a more stable look. It's over 14 days, and it looks at the number of new cases per 100,000 people, average over 14 days. And if you look at the one on the left, it's going to be over 7 days. And the one on the 7-day is kind of a gradated scale, so you can see from lighter to darker colors as you see more cases. You can also hover over those regions and get the actual number. These are going to be applied to behavioral health regions because that is where people move and they have at least 20,000 people in their community. And this is a tool that communities can use and schools can use to get an estimate of what their community transmission looks like. Next slide, please. We're also asking schools to be looking for early warning signs, such as schools to perform symptom screening. If several children in a school or community have new symptoms, they will draw increased attention. If there's contacts to others and considering small outbreaks and helping schools to think about how they could prevent these outbreaks. We're also asking schools to think about what ways they can isolate specific cohorts and classrooms to avoid school closings and to minimize impact to communities as a whole. Next slide, please. Distance learning ready. DEED is working to make sure that we have, I believe that this actually next slide is for Commissioner Johnson, but I'm happy to continue moving on. But I will just continue on until the next break with questions. Distance learning, DEED is continuing to work to make sure that every student and teacher is supported when remote learning must occur. DHSS is partnering with DEED with individual districts to provide decision-ready support tools, taking into account both the community transmission, as we just talked about, as well as school-specific factors. Schools will help parents decide whether learning options are best for their child, and parents will be presented with robust 100% remote learning alternatives. Next slide, please. Maximizing physical distance and face coverings in schools. So here's some data and science specifically on these two factors. In one large review of 172 students in 16 countries, that looked at specifically COVID, SARS, and MERS. Virus detected about 80% when virus decreased approximately 80% when distances of greater than 3 feet and 90% distancing of 6 feet were taken into account. Face masks, including cloths and medical face masks, reduced transmission about half in the non-healthcare setting. And eye protection reduced the infection in one group of healthcare workers from 16 to 6% in combination with other measures. The best protection is using all of the above. We often talk about this in terms of a car. It's not just seatbelts or airbags. It's using all of these preventive measures in combination. Next slide, please. Something else that we've been talking a lot with schools about is age-appropriated cohorting. When middle and high school students can be expected to maintain physical distancing, it can make a big difference in being able to minimize the degree of transmission, as well as keeping cloth face coverings on at all times. Younger children, however, will have more difficulty with these recommendations. Dividing younger children into cohorts or small groups and then ensuring that children stay in their groups for all their activities without mixing can be another important strategy for transmission rate reduction and reducing the number of contacts that any child has. This reduces both the risk to each individual child and family and the risk the child poses to others by exposing them to fewer people. And you can see in this slide where we've kind of demonstrated with a red dot someone who has COVID, who's mixing with others, how quickly it can spread to other people within that group. But if you cohort that same number of kids into 3 separate groups, while it may spread within their cohort, it isn't going to spread to the same number of people. We use similar techniques in the healthcare industry, seafood industry, and other ways to where we're trying to minimize the spread to numerous people. Next slide, please. Any questions I'm happy to talk about, as well as our team, who I greatly appreciate being on the line as well, about transitioning to opening to schools. And now I'm going to turn the presentation back over to Commissioner Johnson for further questions.